So there was a point in the guidelines where if the LDL was less than 40, we would cut the statin dose in half, and then we kind of reversed course on that and really want to try and drive that LDL cholesterol as low as possible. So I do try and explain to my patients, because they sometimes will see numbers in the 20s and 30s with their LDL, that number is important, but there are other effects, especially with statins, where it helps to decrease inflammation and plaque rupture, that we don't just look specifically only at the number.
Welcome to Medication Talk, an official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, and the most trusted clinical resources. Proud to be celebrating 40 years of unbiased evidence and recommendations. On today's episode, listen in as our expert panel discusses the latest recommendations for managing medications after heart attacks and other cardiac events. You'll hear our panelists review which antiplatelets to use, the optimal blood pressure meds, and the role of statin and non-statin cholesterol meds. Our guests today are Dr. Danielle Blais from the Richard M. Ross Heart Hospital and the Ohio State University Wexner Medical Center, and Dr. Joel C. Mars from the University of Tennessee Health Science Center. You'll also hear practical advice from panelists on TRC's Editorial Advisory Board, Dr. Andrea Darby-Stewart from the University of Arizona College of Medicine, Phoenix, and Dr. Craig Williams from the Oregon Health and Science University. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's join TRC editors, Dr. Sarah Clockers and Dr. Stephen Small, and start our discussion.
Antiplatelets are used to prevent clotting and major adverse cardiovascular events during and after ACS, but this also needs to be weighed with their increased bleeding risks as well. So to jump in here on this topic with antiplatelets, Craig, what factors play a role in which antiplatelet regimens are used after ACS?
When we're getting those patients ready for discharge and or handing them off to our outpatient colleagues, I mean, kind of the near-term post-ACS setting, I'd say the big complication these days is we've learned a lot about our patients who are on an oral anticoagulant, and we need to think differently about if they're on an oral anticoagulant going home or were on it prior to the ACS or not. And that been a big kind of change in the guidelines. It's been kind of brewing for a couple guidelines, and ACC-AHA, as Joel knows well, the cardiology guidelines, there's different groups writing different things, and there's guidelines for PCI and now guidelines for chronic coronary disease. But we kind of have a somewhat unified guideline now. So if we're receiving those patients in the kind of outpatient setting and they've just had an event, then the recommendations kind of range from aspirin by itself once you're truly stable to actually no antiplatelets if you have chronic stable disease and you're on a DOAC. But in the setting of acute coronary syndrome, which you asked about, so if I have an acute coronary syndrome, to some degree, it's dual antiplatelet for some duration of time. And the considerations, again, are, do I have an anticoagulant? And then what specifically was my acute coronary syndrome? So was it a STEMI or a non-MI event? But the big factors to consider are, is my patient on an anticoagulant? And then what event do they have and what was done to them in the hospital? So because CABG is managed a bit differently than PCI.
So I think, first of all, would be the basic contraindications and precautions for the medications would be the first thing to consider. And then looking at patient-specific factors that may go into the antiplatelet that we would choose. Specifically, are they able to afford it? Their compliance with medications or adherence to medications and being able to take something once a day versus twice a day. And then ultimately other procedural factors such as what type of stent was put in, how many stents are also things that I would consider. And then lastly, other concomitant medications that the patient would have to be on, such as anticoagulants.
Great. And that kind of leads to this proverbial question with dual antiplatelet therapy. How long should they be continued after ACS? And also, what factors influence that decision?
So, as far as the duration of dual antiplatelet therapy, some of those things that you consider as far as which antiplatelet or P2Y12 inhibitor also would go in and I think be considered for the duration of dual antiplatelet therapy. I know we'll talk about anticoagulation later on, but if they do have to be on anticoagulation in addition to antiplatelet therapy, that does play a very large factor into the duration of dual antiplatelet therapy and specifically getting down to one of the antiplatelet agents to minimize that bleeding risk. And then also procedural factors such as, was it a left main stent? Do they have multiple stents, overlapping stents? All of those things may go into a longer duration of dual antiplatelet therapy. And fortunately for us, I think people are more looking into specific scores or ways for us to determine the duration of dual antiplatelet therapy. I think that's a field that we have a lot more to learn about, but sometimes us kind of just picking out of the air the duration of dual antiplatelet therapy versus having some very objective ways of looking at it can be more helpful.
I'll just add briefly, Steve, that because when teaching internal medicine residents and family medicine residents and even medical students how to think about this in their future patients, it's kind of as little as a month for dual antiplatelet dependent setting and generally not much longer than a year. So it's kind of between a month and a year. And as Danielle said, occasionally for longer term if they're really stable.
I think there's definitely some provider specific approaches, but with the guidelines being updated recently, I would say there's been probably even before that update in the guidelines. In my practice, a shorter duration of dual antiplatelet therapy, especially in those that are considered high bleeding risk or have a history of bleeding. And so I would say kind of backing off to SAPT or single antiplatelet therapy a little bit quicker than we once used to, but there still are those individuals that will continue on for that full year out. I would say I don't tend to see a ton of patients that are on kind of that DAPT beyond that 12-month window as we used to see some of those in the past.
Great insight there. What dose of aspirin do you recommend post ACS?
So the bulk of the data kind of aligns with low dose aspirin at that 81 milligram dose for kind of chronic maintenance therapy post ACS, acknowledging that they're going to get a loading dose during that acute presentation, but chronic use would be that 81 milligram.
Great. Now that we've talked about dual antiplatelet therapy and single antiplatelet therapy, let's add another dimension, triple antiplatelet therapy. So when should patients be on that and how long should that be used for?
This situation arises when patients have an indication for anticoagulation in addition to their DAPT. And so commonly could be atrial fibrillation or history of clotting in the past. So they could be coming in the door on anticoagulants, or it could be diagnosed and started during the hospitalization as well. The latest update and recommendations from the 2025 guidelines have discussed and trying to back off on that DAPT piece as quickly as possible. And so they actually have a recommendation if patients are going to need to be on anticoagulants in addition to their DAPT, that backing off within that first month. Some data supports even after a week of DAPT, but I would say more consistently in practice would be a month of triple therapy and then backing off to a DOAC plus a P2Y12 inhibitor. And then once they're out of that thrombosis risk window with antiplatelets, then going back to the DOAC alone based on their indication.
Thank you, Joel. And to clarify, the DOAC anticoagulants we're talking about here specifically are apixaban, dabigatran, edoxaban, and rivaroxaban. I really like that AFib example, and it shows that these meds play an important role for many of our patients with additional indications. Now over to you, Sarah.
Thanks, Steve. Now let's move along to talk about blood pressure management and the role of ACE inhibitors or ARBs post ACS. And Andrea, can you start us off? What blood pressure goal do you aim for with patients who've just had an MI or have unstable angina?
So typically, the blood pressure goals that we're looking for are going to be generally in the less than 130 over 80 range, although I understand that the American College of Cardiology still allows us to be in a target range of at least less than 140 over 90. We do know that if we drive blood pressures too low in the less than 100 to 110 range, then we can actually have increased adverse effects. With appropriate shared decision making with patients, I generally try and have my patients post MI in the less than 130 over 80 range.
Great, thank you. Blood pressure control is key to lowering cardiovascular risk, and both ACE inhibitors or ARBs and beta blockers are considered important components of secondary prevention after an MI. So let's start with discussing the renin angiotensin aldosterone system inhibitors, specifically focusing in on ACE inhibitors or ARBs. So, Joel, can you comment on which med class is more effective and if there's a best ACE or an ARB to use?
Yeah, that's a great question that comes up frequently. I would say, based on the literature and clinical trial data, when you compare ACEs and ARBs, there's really not one that's better than the other. And even within the class, because there are class effects on the benefit of reducing MACE in these patients long term, there's really not necessarily a preferred agent. I would say clinically, you're probably not going to be routinely using, say, ACE inhibitors that need to be dosed twice or three times a day versus once a day to help with medication adherence. But overall, there's really not necessarily a preferred. One of the biggest things is making sure the patient can actually get the medication. And fortunately, because we have generically available ACEs and ARBs, that usually is not an issue.
Excellent. Thank you. Danielle, would you want to chime in on that? Do you have anything to add?
The only other thing, which I know this wasn't part of the question, but I think does come into this picture is use of a sacubitril valsartan also. I typically tend to stick with either ACE inhibitor or ARB, and I think one isn't necessarily be more effective than the other. And I don't really have a true preference for any one over the other than maybe some of them might be dosed twice a day, so just looking at that versus the ones that we would dose daily.
In the setting of hypertension, and Danielle's right, for if it's heart failure, we have to think about some other things. But in hypertension, we're kind of teaching to be an ARB first, more for tolerability. So as Joel said, there's really not an efficacy difference. We have inexpensive ARBs now, and they are better tolerated. There is less angioedema and a bit less dry cough, and it kind of makes a difference over hundreds or thousands of patients in the healthcare system. So we don't see a reason not to be leaning towards ARBs, more for tolerability, not for effectiveness.
Excellent point. And then we've had a couple of questions from pharmacists saying their patients are on an ACE inhibitor with an ARB. Is that recommended? Joel, would you want to tackle that one?
Sure. So, really, there's not a huge role for the combination therapy. There's really two subpopulations that there's actually any data that could support a potential benefit. One is in heart failure, with one clinical trial demonstrating that adding an ACE to an ARB is an option. But I would say, with the changing landscape and the use of ARNIs quicker and heart failure management with reduced ejection fraction, I would say that's really not necessarily an approach that's taken commonly. The other areas, if someone actually has gross proteinuria, there is some data to support further reduction in spilling protein with the combination, but really that's not necessarily a commonly seen thing. And the reason for that is that there was one clinical trial on Target that basically compared an ACE inhibitor to an ARB in the combination, and there really was no difference in efficacy from a major cardiovascular event standpoint, but there was higher toxicity. So you saw more hyperkalemia, you saw some more renal dysfunction associated with the combination therapy. And so in general, management of hypertension, it's not necessarily a recommended approach, one or the other, but not both together.
Thank you. And I'm going to move us along to beta blockers. So, Danielle, would you want to comment on which beta blockers patients should start and when they should start them?
So, first, as far as which ones should be started, a lot of this can often be driven by the fact that patients with post ACS may also have heart failure. So, we have our evidence based beta blockers that can be used for those patients. I would say most commonly carvedilol and metoprolol succinate are the extended release form of metoprolol and possibly bisoprolol. If they don't have heart failure, often the next consideration would be, is the patient someone that you're more trying to control their heart rate, which we would lean towards metoprolol succinate because of its activity at the beta 1 receptor, versus someone that maybe needs some help with lowering their blood pressure as well as controlling their heart rate. Carvedilol is one that we commonly would reach for. I think the next question that you had is, when should we start a beta blocker? I think this is a little bit of a loaded question now with some of the trials that have most recently been published with use of beta blockers in this patient population. But kind of considering for arrhythmias, for example, then a beta blocker started sooner. If they can tolerate it, would be best. And then looking at patients who maybe don't have arrhythmias or heart rate is not a concern, but would maybe be more compromised by putting on a beta blocker. So elderly patients or patients with low blood pressure without arrhythmias should be considered. So I think this is probably one of the areas in comparison to 20 years ago when I started practicing that there's kind of been maybe a little bit of a paradigm shift.
Joel, do you have any comments about when to start? And then I would also love your thoughts on how long patients should be on a beta blocker in light of the recent guidelines and more recent evidence.
Yeah, so I would say the same points in regards to starting it that Danielle brought up. I think the question of length of therapy has kind of evolved over the last number of years. And so the guidelines discuss, treating out to evidence is supporting out to at least 3 years post ACS. But as we've kind of seen with some more recent trial data, supporting that if someone doesn't have reduced ejection fraction heart failure and has preserved ejection fraction, that there's not necessarily benefit extending out even beyond a year. And so you're starting to see some practice change and some patients only being on a beta blocker for somewhere between 1 to 3 years, depending on their provider and that patient discussion.
Great. And then if somebody is stopping a beta blocker, how would you advise they do that safely?
So in general, it should be tapered. Usually it's safe to taper a beta blocker off over anywhere from kind of 1 to 3 weeks. Some of it's dose dependent of how high of dose the patient's on. And so maybe a longer taper if they're on a higher dose, but usually somewhere in that 1 to 3 week window.
And then we did have a great subscriber question, and I'd be curious to see, Andrea, you probably see these patients in your practice after the fact. If a patient's having a low blood pressure on the ACE inhibitor and beta blocker, which med should you lower or stop first? Does one med class have more benefits than the other? So, do you have any comments there on your approach to managing these patients post ACS?
Yeah, I would say that the majority of my patients who aren't tolerating their medications are generally not tolerating the lower heart rate with the beta blocker. And after discussion with them, will generally choose to continue an ACE or an ARB and taper off of the beta blocker to see if they tolerate that well. Again, that goal of ensuring that we manage their blood pressure and keep them in that less than, 130 to 140 over 80 to 90 range so that we can do good secondary prevention.
Excellent. Does anybody else have a different approach in this scenario?
No, just add that it goes back to kind of knowing for sure what happened with your patient's ACS and how they were managed. If you want to really optimize it, to Danielle and Joel's points, there's antiarrhythmic benefit from the beta blocker, and if there is ischemic damage that was not able to be addressed or reversed, then there is some kind of time-defined benefit of that beta blocker. Whereas, the ACE and ARB, if there's no left ventricular dysfunction, that's really kind of more questionable. Fine for hypertension, but not really an intrinsic ACS drug. But a beta blocker can be, depending on if there's residual ischemic damage, depending on how the ACS was managed.
Thank you. So let's move along to lipid lowering meds. Joel, we'd love your thoughts on the latest approach to lipid management. Are we targeting certain LDL or specific doses? What's the latest approach with the latest guidelines?
Sure. So the full guidelines from ACC/AHA date back to 2018. There was an expert consensus decision pathway updated in 2022. And that's where some of the more recent data kind of came out and is in alignment with the chronic coronary disease guidelines as well as ACS now. As it relates to the terminology, currently they're still using terminology of thresholds instead of goals in the current landscape. But that threshold actually in these very high risk ACS patients is now recommended at 55 milligrams per deciliter. And so with that more aggressive goal, that's also brought up that many of these patients are needing 2 and 3 lipid lowering agents to actually get to that aggressive target. Most of the patients that fit into the ACS bucket fit into that very high risk. So having an event plus multiple risk factors, we still do want to target that at least 50% reduction, which ties to utilizing high intensity statin doses with atorvastatin or rosuvastatin. But you do have some patients that fit into that high group that you could get away with a less aggressive threshold or target of less than 70. But I would say most of these patients are going to fit into that more aggressive, less than 55 goal.
Thank you. Another question. What do you tell patients worried about their LDL being too low? And is there an LDL that's too low? And what's the evidence there?
Yeah, so I think this is a question that we've often seen change over the last few years. So there was a point in the guidelines where if the LDL was less than 40, we would cut the statin dose in half. And then we kind of reversed course on that and really want to try and drive that LDL cholesterol as low as possible. So I do try and explain to my patients because they sometimes will see numbers in the 20s and 30s with their LDL that number is important, but there are other effects, especially with statins, where it helps to decrease inflammation and plaque rupture, that we don't just look specifically only at the number. This is also an education point for providers when we're rounding because a lot of the new interns and residents will see a low number like that and maybe want to knee jerk dial back therapy. With the addition of the PCSK9 inhibitors, as well as some of the data where we were looking at high intensity statins and moderate intensity statins, we saw that there wasn't some of the safety concerns that maybe once were thought to be had with those low LDLs. So just kind of emphasizing to them that we do want that number low to prevent future events.
Excellent. And then, Joel, you had alluded to, those high intensity statins being first choice post ACS. And so, question for you with the recent guidance, when should you start a high intensity statin alone versus a high intensity statin with the ezetimibe? And then we have also had the question from a subscriber, is a moderate intensity statin plus ezetimibe okay if the patient doesn't want to use a high dose or a high intensity statin? So what are your thoughts on, jumping to 2 meds after a patient has their first event?
That's an excellent question. And it is addressed in the new 2025 ACS guidelines. First line and still recommended as kind of the core approach is using a high intensity statin upfront. They did give a lower level recommendation, I believe a 2B recommendation, that you could start with a statin plus ezetimibe. Some of the driver for that is a trial that safely showed that you could use simvastatin as ezetimibe as a combination therapy within 10 days of an ACS event and showed further lowering versus a statin alone. But I would still say the strongest data is for that high intensity statin monotherapy up front. I think you could justify in some patient populations, depending on what that baseline LDL is, if you know that they're going to need more than a 50% reduction. I think it's very reasonable to start the combination of a high intensity statin and ezetimibe together with that approach, especially in those knowing that you're going to need to get to that threshold of less than 55. And so I think that's an option in some patients.
Great. And Danielle, what are you doing in your practice with post ACS?
Yeah, I think Joel hit the highlights. So we do try to start with a high intensity statin, But if there's a patient that needs a much bigger lowering of their LDL, we tend to use high intensity or moderate intensity statin plus ezetimibe, just because by doubling the dose of statin, you often don't get as much of an LDL lowering as you would with ezetimibe. And if there's any hesitancy in the patient taking a high intensity statin or previous intolerance, I'd rather do that than risk the patient not taking it. We've been a lot more aggressive, especially when we have patients that have extremely high LDLs, at trying to get them set up with a PCSK9 inhibitor at discharge or with close follow-up with a pharmacy clinic to make sure that those get started.
When you're starting those, are you starting those alone or are you adding those on to the high intensity statin and ezetimibe?
Typically, if we send them out and they're not on the PCSK9 inhibitor at discharge, we'll do a statin plus ezetimibe, and then with the hopes of getting that PCSK9 inhibitor started, especially if there's somebody that has an extremely high LDL. If there's someone that we can't think that we can get the PCSK9 inhibitors, like, no, they have it in hand when they go, plus the statin, we may forego the ezetimibe. It just depends on the patient, the number of medications they're on, and if we think one less medication is really going to make a difference as far as their ability to kind of keep up with the regimen that we're sending them out on, we may or may not do that. But if there's any question about, coverage of that PCSK9 inhibitor or starting it, then we typically will use ezetimibe and then maybe dial back later on down the road.
Great. Thank you. So now I'll hand the reins back over to you, Steve.
Thanks, Sarah. And let's move over to anti-anginal meds. Who should get anti-anginal meds post-ACS? Is it a select group of patients?
So it's going to be related to the kind of patient's presentation and their history. So if this patient has a history of angina prior to their ACS event, then those are people that should be on anti-anginal medications. The fortunate thing is that most of these patients are already going to be initiated on a beta blocker with their acute management treatment. And so already going to have that on board. But any history, they should have a quick acting sublingual nitroglycerin available to them as well, just so that they have that if they do need to treat angina symptoms moving forward. And then over time, then assessing, are they still having angina post-ACS event? And if so, maximizing their other therapies that could potentially lower the risk of having kind of chronic angina go on.
Great. And Danielle, are certain nitroglycerin dosage forms more effective than others that we should be leaning towards for these patients?
So I think in order to answer that question first is knowing whether you're talking about the acute management. So sublingual nitroglycerin, or some patients will prefer the nitroglycerin spray, versus if you're trying to provide chronic anginal coverage. And so that really often depends on the patient preference and tolerability. Some patients may prefer a long-acting nitrate. I've had other patients where, depending on when their angina occurs, if they're not responsive to the long-acting nitrate, may do better with a nitroglycerin patch. And there are some patients where we've had to use, albeit maybe not as common, different combinations of the long-acting nitroglycerin and patch. Obviously not at the same time, but at different points during the day. So I really think the effectiveness often depends on how the patient responds and tolerates the different nitroglycerin forms.
And then, Joel, the question we sometimes get is, can you combine different anti-anginal meds to kind of boost that effect if needed? Do you ever see that combination? Do you recommend that?
Yeah, so the chronic coronary guidelines as it relates to angina management chronically still recommends beta blockers as the first line therapy option there. And then combining agents, it lists options that you could use a dihydropyridine calcium channel blocker in addition to a beta blocker, or potentially a long acting nitrate product could be used safely together. There is some data to support all three of those can be used safely together as well. What we generally try to avoid, and this is based on the patient's response from a heart rate standpoint with the beta blocker, is generally you're not using the combination of a non-dihydropyridine with a beta blocker, even though that in some rare instances does come up in regards to lowering a patient's heart rate. But most of the time, it's if you're going to combine a calcium channel blocker, you're going to use a dihydropyridine with a beta blocker.
And Andrea, what are some counseling pearls for patients getting nitroglycerin tabs? For example, I know there could be some storage things to think about, but also we sometimes get the question, can you get addicted to nitroglycerin or become dependent on it as needed? What's your take on that?
Sure. And I have many of my patients walking around with their nitroglycerin tablets conveniently tucked in their shirt pocket or stored in their car or places where they probably shouldn't be. So, really trying to emphasize that, gosh, you should really try and keep the tablets in a temperature controlled environment and not let them get to body temperature or above in the setting that I work in is important. And then, people perceive pain and medications that take away pain is something that they can become addicted to. So, really helping them understand what this medicine is supposed to do for them in the event that they do have anginal symptoms and that they can't become addicted to it in the manner in which they have heard other medications like opioids are addictive.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a pharmacist letter, pharmacy technician's letter, or prescriber insight subscriber, find out more about our product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.